I'll introduce Dr. Kamran Ahmed, first of all, who's a GP. They're the gatekeepers of our health service. And I guess it's fair to say that in any GP practice, they may only see 1 or 2 patients with esophageal atresia. So it's, for us, it's a rare disease, for a rare condition. For a GP, it's an even rarer condition to have a child or indeed an adult in your family practice with this condition. Ahmed also has a child with esophageal atresia, am I correct? So he's actually, I'm sure, read a lot more about this condition than your average GP, who will probably just remember this condition as something they learnt in pediatrics when they went through undergraduate medical school. So Kamran, why don't you kick us off, and our other speaker is en route, who's an adult upper GI surgeon. So the floor is yours, okay? You're very welcome.
Thank you for having me here. As I've already been introduced, my name's Kamran Ahmed. I'm a GP. I'm also a parent of a now 4-year-old who's a TOF. Before I start the slides, I just want to say the word rare has come up quite often in the last couple of presentations. And when people say rare in the TOF context, it's actually more rare than rare. So some of the things that you've heard about vanishingly rare. So this is what I call the ego slide. So this is a little bit about me, but also gives you a little bit of an idea about why I'm here and maybe why I have some authority to talk at this event. I'm a GP. I graduated from Sheffield. I'm what you call a portfolio GP, so I have lots of other roles. I work within a practice for 25 hours a week, but the rest of the week I have lots of different roles. It includes working for the Ministry of Justice, so I am going to touch really quickly on things like benefits and those kind of areas. And I do a little bit of work with boxing. So it's controversial for doctors to work in boxing. I'm a controversial doctor. And in the top corner is my little one who was born with TOF OA, and he's now thankfully doing very, very well. This is your standard Google snapshot of what a GP's life is like. We're all happy, we're all smiley, we're all doing really well. We all wear suits and shirts and ties to work. In reality, that's probably more of a realistic picture of a GP workload. Now, I was doing a little bit of research for this. I did a similar presentation last year, so I wanted to change the slides a little bit. And I found the National Physicians' Burnout, Depression and Suicide Report. And even I was shocked to find that actually general practice family medicine is quite high up in that report. I was even more perplexed about people who play with genitals being at the top of the report. And people who are more interested in what's going on in my head than me being second in the report. But as we can see, family medicine is quite high up. I think this is more of maybe a global picture or an American picture. The picture in the UK would suggest that actually emergency medicine and family medicine are quite high up, and probably even higher up than they are on that report at the moment. This is an idea of what you see when you go and see a GP. So that was me in 2002, rookie medic, that one. And I like to think I'm 10 years down the line, but actually I'm closer to 20 years down the line. There is a point to this picture, actually. So when patients are unwell, generally in the population, but also for TOF patients, when you're unwell, the first thing you think of is, oh, I'll go to A&E. I can't get into my GP, I'll go to A&E. In A&E, you are much more likely to see that person in the top left corner who's had a couple of years out of university and very minimal specialist training versus a GP who's had at least 10 years out of university, if not more, and a much broader understanding of lots of different specialities and how they interact. We all end up in the bottom left corner, unfortunately. So common complaints. There's a list of them there. I think appointments is always the main problem that we get in our surgery. The main complaint that we get is about not having enough appointments or not having enough available appointments. There's also concerns more so now than ever before about will I see a doctor, because we've got expanded roles in general practice, and I'll touch on some of those. The doctor doesn't know anything about my condition. The doctor doesn't understand my condition. And this is where that word rare comes in. So we'll have a little talk about that. The doctor doesn't refer me. I've got a few slides today about how the referral process works from the doctor's side, so you can get an understanding of how you can intervene with that and how you can actually help and guide the referral. I put a message out on the Facebook group a couple of weeks ago about what people wanted me to cover, and I think referral process and pathway was one of the things that was mentioned, so there's a couple of slides on that. The doctors won't prescribe me what I want, and the doctors never call me in for a review. And like I said, I'll quickly touch on benefits, because we're talking about more towards the adult TOFs. We have a lot of people who transition from child to adult, have been on benefits through childhood, and then suddenly find that that's not the case when they're an adult. So the importance of GPs, a few statements from politicians about how GPs are the bedrock of the NHS. If general practice fails, the whole NHS fails. And actually, the NHS is built on having family medicine as the first point of care, and that's why that statement is very true. I feel patriotic. So my experience, just to go back a little bit, I actually started off doing surgical training, and my last job was a registrar in upper GI surgery. And as was mentioned before, surgery became more and more specialized, and it wasn't something I wanted to do. I wanted to get out and do more of a generalism. I always thought I was too tall and my arms were too long to be a pediatrician, but we've been proven wrong today. So, the GP workloads. We usually, as a GP, for every GP that's in your practice, they will have approximately 2,000 patients allocated to them. So if you go to a surgery where the list size or the registered patient size is 10,000 and they've only got 3 GPs working there, they're probably understaffed. And that's the average that we are told to expect, is about 1 GP looking after 2,500 patients. In a given day, we have typically 10 and a half hours. So we start at 8, we finish at 6:30. And there are lots of jobs that need to get done through that day. So we have a number of prescriptions, we have patients that we need to see, we have administration that we need to do, and we need to make sure that we don't overrun. We have home visits. So GPs don't like doing home visits. The reason why is that a home visit will take me typically 45 minutes. In 45 minutes, I can see 4 or 5 extra patients in the surgery. So actually, the resource time for that one patient that requires a home visit is substantial compared to what I can do when I'm actually in the practice. The other reason why is that on home visits, it's very difficult to take all the medical record with you. So you're making decisions based on less knowledge in front of you. But we do them. We do them for those patients that desperately need a home visit, who are housebound, who are struggling to come to the surgery. We probably do more for children and elderly, so the both ends of the age range, than we do for people who are younger. We also get involved in doing cremation forms. So unfortunately, when somebody passes away, we have to do all the documentation, which includes death certificates and also cremation forms. That normally quite a bit of GP time taken up in running around to funeral directors to get the forms filled in so that families don't have delays with burial processes. We are more and more often involved now with decision-making with the local authority. We then rush back, have an afternoon clinic, and after the clinic, we try and make sure there's nothing left that's come through the system. So we have electronic systems that talk to the hospital, that send us all the blood results, send us all the letters, and we need to make sure there's nothing in there that's urgent that I can't leave overnight. Because quite often we'll get a blood result that I took at 8 o'clock in the morning. It sat in my surgery till 12 o'clock when the driver turned up. He took it to the hospital received it at 2, they put it on the analyzer, they get the result back at 5, and they send it straight back to me and say, something's majorly wrong here, you need to do something. And that's not unusual. So we get a couple of those a week where we have to just make sure that what we leave overnight is safe. We typically get 40 letters per day. So in medicine, there are over 150 subspecialties, and each of those subspecialties will have patients that go and see them. And each of those subspecialties will then write to us to say what they've done with the patient and what changes that need to be made to patient medication or to their care. Typically, that's a 14-hour working day squashed into a 10-hour working day. And then general practice, a lot of it is a business. So a lot of GPs have their own practices. So there's a lot involved in running a business. Those of you who are self-employed or run a business will know that actually there's quite a substantial amount of administration involved in the bookkeeping side of things, but also checks and balances for what you're getting in and what's going out. The NHS's expectation is that GPs will start working 8 till 8, 7 days a week. But that means it'll be more difficult to see the same doctor, because 8 till 8, 7 days a week means that we need to get more doctors in, and it means that you will not be able to see the same doctor regularly because we'll start working rota patterns and shift patterns rather than working within the surgery for our full 50 hours a week. And it is usually a 50-hour week. We do work quite closely with ambulance services and community nurses. One of the main roles of the GP is to orchestrate what happens in the community. So we work closely with district nurses, community nurses, and other community-based services to try and make sure that patients' care is optimal. We also have a lot of reports to do, which includes the insurance reports. So if you apply for an insurance policy, at the back end, we'll get a letter saying, please, can you give us a full report on this patient's history, because we want to underwrite the insurance policy, and therefore we want to make sure that the decision is fair and appropriate. This is Dr. Shipman. I thought I'd just put that slide on there. I don't know if many people here will recognize that name and that face. After the Shipman era, we were left with a legacy of revalidation and appraisal. So this process means that GPs every year will go through a process of collecting data and have to do a minimum of 50 hours a week. 50 hours a year, sorry, not 50 hours a week, no. 50 hours a year of personal study and courses to show that they are developing their knowledge, okay, on top of everything that I've already mentioned. So if you're a GP, if you've got GPs in this room, a few tips: take your work home, have a wee at home, have a big breakfast, and plenty of coffee. And actually, my staff use coffee to bribe me quite often. So they'll come in and say, oh, this prescription's urgent, can you sign it, please? And I'll give them a frown, and they'll say, I bought you a coffee. I'm like, okay. So have I gone backwards? What's happened there? What's happening at your surgery? Just really quickly, I just thought I'd put this slide in. It gives you a list of some of the common services that happen within your local GP practice. We don't just see patients. We don't just see people who are suddenly unwell. We actually do a lot with people who have chronic illnesses. Some surgeries do minor surgery, all surgeries do dressings, injections for vitamin deficiencies, child immunizations, and the list is as it is on there. I've put the average time that appointment will take next to it. Okay? So surgeries are a hive of traffic. They're extremely busy all of the time. That's why some of our receptionists can get frustrated, but equally why some of the patients can get frustrated. I quite often speak to receptionists about the way they manage the patient, because on both sides of that equation there's frustration. There's frustration from the receptionist because actually they're not medically qualified. They are there just to try and see if they can make more efficient the GP's day and help the patients. And the patients are unwell. And all of us know that when we wake up with a sore head and we don't feel well, that's when we're more likely to get irritated and more likely to get angry. So it's very difficult to balance that, and we quite often get patients who are aggressive or who are angry. And unfortunately, not so often, but rarely, we have to get patients removed from our registers because of their attitude and behaviour. And the NHS has a zero-tolerance approach for that kind of thing now. So these are the concerns that people have. Appointments are never available. As you can see, the surgery is busy. And actually, when patients say to me appointments are never available, I look at my appointment book, and there's 1,000 people that have attended the surgery in a week. And I think, well, what more can we do? We've got 1,000 people coming through the door in a week. But we've got aging populations and medical complexity, which means that we need to see patients more and more. We have hospitals telling us that actually, wouldn't it be easier for the GP to monitor this patient or follow this patient up or do the annual blood test for this patient and then just let us know if there's an abnormality? And there's a big drive to move work from hospitals back out to the GPs because the GPs are thought to be better at monitoring. We have the now culture, so we do have people who say, I want what I want and I want to be seen now. And it's not unusual, as you see from the TV programs with patients attending A&E for broken fingernails, it's not unusual for people to say, I've woken up with a cough. I've woken up this morning, I've got a sore throat. It's not unusual for some parents to book in just because they want us to prescribe paracetamol for the young ones. Okay? It's very difficult to manage that. Some surgeries use a triage system where they'll phone you back and ask you what the problem is and talk to you. But that takes resource. It takes a person off doing appointments and seeing patients and putting it into a different part of the practice to manage that. So we have now a lot more patients who we support with dying at home. And one of the pushes from the hospitals is to try and make sure that patients don't die in the hospital. It's not a nice place for people to die if that's not what they want, if that's not their choice. And actually we try and support them by either helping them at home or guiding them through the process and then getting them into a hospice in the last days. So just a few tips. The practice will keep about 2/3 of the appointment for the same day. Now, again, we all phone the surgery at 8 in the morning. We can't get through for half an hour, 40 minutes. And then we phone later on and say, sorry, there's no appointments left. The reason you can't get through is because of the rush. It's not because we've taken the phones off the hook. I wish we did sometimes. There are now novel ways of making an appointment. So we do online appointments. A lot of surgeries now are moving to an app that you can have a look at the appointments available over the next few days, and you can book an appointment via an app. A lot of surgeries also now, over the last year, do what we call enhanced access. So rather than being seen in your own surgery, you can phone up and they'll be able to book you into a hub where a number of surgeries have come together and they make appointments available. And then you can be seen in that hub, but the hub will have your full medical record. So you won't get your GP, but you will get a GP or a suitable practitioner who has access to your record, who can do the assessment, have a chat, and actually sometimes have more time. So when I'm working in the hub that I run, it's a 15-minute appointment. When I'm working in the surgery that I work in, it's a 10-minute appointment. So learn your practice system. The important thing is to try and see if you can have a meeting with the practice manager or be nice to the admin staff on reception and learn your practice system. Go there when you're well. Ask them, what system do you run? How can I make an appointment? What's the easiest way to make an appointment? All practices, as we mentioned before, there's a lot of power in people when it comes to politicians. And all practices will have a patient participation group. So if you go to your patient participation group and join the participation group, you can actually have a much better insight into the way your practice runs, and you can, to some degree, control the way that your practice runs. Okay? We often use, in my practice, we often use our patient participation group to help us respond to complaints, so that we get a better understanding of why the person's complained, and equally, we're able to give a much more refined response back. Don't be fussy about the doctor or the nurse that you're going to see if it's an acute problem. If you can wait, book for the doctor or nurse that you want to see, brilliant. But if it's something that's acute and you need to be seen, just get in. Once you're in, the head of that pyramid is always the GP. So if the person who sees you can't deal with the problem that you've got, they will just say, hold on a minute, let me go and knock on the door of the GP. And so if you do need the GP, if that patient can't manage your care, they should then call the GP in, and the GP will then be able to add on to the assessment. There's a lot more of this now with nurse practitioners and clinical pharmacists, and we'll come to that in the next slide. So yeah, will I see a GP? Will I see a doctor? I have a number of nurse practitioners and clinical pharmacists who work for me now. We were one of the first surgeries in the country to take on clinical pharmacists, and I've trained probably about 30 to date, but the number grows exponentially as pharmacists realize that this is a role that they can go into. So your pharmacist that dispenses medication actually has 4 or 5 years of university education behind them. They have a much better knowledge of medication, stock availability, what's liquid, what can be crushed, what can't be crushed, than I do. Yeah? Now, there are courses available for them to learn clinical skills, so for them to learn how to examine a patient, how to use basic observation equipment, and how to make diagnosis of infections and more complicated illness. And there are also courses that allow them to actually prescribe. So pharmacists at the moment cannot prescribe unless they've done a specific course. So they are very well trained. So if you have a clinical pharmacist in your practice, if you have a medication issue, they're the person to see. But equally, if you have a sudden issue of a sore throat, a cough, or a cold, or an infection that doesn't seem to be settling down, they can manage that. Nurse practitioners are nurses that have then developed into practitioners, so they've also done a clinical assessment and prescribing course. Many of you have been on wards, and many of you know that there are some really good nurses out there. Well, a lot of them will then go and train to the next level up, which is to do more prescribing and more clinical assessment. And we have some nurses who've done years and years on the wards, on pediatric wards, and have seen lots of people with TOF. And they decide they want to do a clinical practitioner role, and they move into pediatrics. The most common one is respiratory, actually. So we've got lots of nurse practitioners out there who have respiratory trained and then moved into working in general practice. They assess patients and they prescribe. So to get in, because the doctor will always supervise the rest of the team. So if you have a problem and you need to be seen, the doctor is always on site. They can supervise the team. And even if they're not on site, they've gone on a visit or they've gone to sort out a cremation document or some funeral arrangements, then actually the nurse practitioner can speak to them, give them all the observations, all the information, and they can come back to you. It's exactly the same as what you get when you're in a hospital and you don't see the consultant every day, but you see the junior team every day, and then they feed back to the consultant and they come back and say, well, I've spoken to the consultant and they've said do X, Y, and Z. Yeah? We're moving more and more to that model where GPs are actually being used more of a consultant position, and actually we've got other staff beneath us who manage most of the day-to-day work. Be nice to receptionists. I keep putting that in. The doctors don't know anything about my condition. So we've talked about the condition being rare. We've talked about the rare complications of the condition. And we've thought about the even more rare examples where the consultants operated on 5 in their entire career. They will all come to the GP. They will all have a GP that they're registered to that will look after them. GPs know something about everything, which is becoming more and more difficult because everything is becoming more subspecialized. And I said there's over 150 subspecialisms. I've got to know something about them. Consultants are very experienced and know everything about something. I've put some figures in about how rare TOF is and the average list size. So actually, the normal GP might not see a TOF birth or child in their practice for over 30 years, so a whole career. If you can identify a doctor who's got a bit of surgical experience or has had some pediatric experience, you will more than likely get a better relationship and a better understanding of your condition because they've seen the tip of the iceberg. So they have been there in the surgical hospitals, they've gone through those wards, they've seen children with TOF, and they also understand the surgical terminology better. I was also, part of my role with TOFs, I was responsible for supporting the creation of the TOF flyers, the little cards for GPs. There's lots on the front desk downstairs. Take those, give one to your GP. So when you go in, give one to your GP. One of the things that GPs have that is a very powerful tool is your medical record. And actually, your medical record with the GP is more advanced than your medical records with the hospital. If many of you still attend outpatient appointments, you'll know that somebody will come along with a trolley, normally somebody who needs to retire but just doesn't want to, will come along with a trolley full of notes, and then the consultant will do lots of page flicking and then lots of scribbling on the papers. We don't do that in general practice. We use computers, we have databases, we've been collecting patient data for over 30 years. So actually your medical record, the entire lot can be printed out for you in minutes. And we have systems to interrogate that record so we can identify what medication you've had for the last 30 years. The doctors don't refer me. They want to save money. The first thing that's changed is probably the line in the red in the middle. So we are much more minded that the NHS money is short, and the services for social services are not luxury services. I apologise for the slight overlap in the image there. And so it's not what do I fancy anymore, it's what do I need. And so we have daily battles with patients who are concerned about an element that probably can't be dealt with or can't have anything done with. Now, if I have a conversation with a patient and then do a referral, the referral does cost money, but that does not come out of my practice budget. It does not affect the running of my business. So it's not about the money. It's about managing the expectation. So if your expectation is that you want something done, then the GP's conversation is about how real is that expectation and how necessary is that outcome that you want. And that has changed a little bit, because in the past you could go to the GPs and you could ask for anything and they'd just refer you to anywhere and everywhere. But we had a system that was flooded full of patients, and patients bouncing around and not coming out of the system. So there's much more work now to try and get patients out of the system, and manage more of what is necessary, what people need rather than what people fancy. When it comes to medication, the issue is that there are lots of lawyers and solicitors out there watching over us, desperate for us to prescribe something that's not licensed or that we are not allowed to prescribe because we have a limited scope within our prescribing. Now that might sound a bit silly. Hold on, you're a doctor, you should be able to prescribe anything. A lot of medication that's used at the hospital is used because they are specialists, and therefore they can keep a track of patients in whom they start a medication on. They will also be the first to use novel medications, new medications. They are quite often approached by manufacturers of new medications to say, look, what my medication can do. Try this on your patients. It will help them. But those medications need a license for a GP to be able to issue it. If I issue a medication without a license, it can get me into trouble, because I've issued something that I've got no experience of working with, and I've issued something that I've got no experience of what the outcomes of that medication might be in managing some of the side effects. So GPs are very careful about what they prescribe. We now do write quite a lot back to our consultant colleagues to say, please can you issue the initial prescription, make sure that the patient is stable on it and there's no side effects, and then we'll try and carry the rest of it on. Or, I'm really sorry, but I can't prescribe this because it's not licensed, so I'm not allowed to prescribe it. We used to pay up to £10,000 a year in indemnity, so in insurance, to work as a GP. That has now changed, so there is now a government scheme for insurance, so GPs don't pay for their own insurance. But the government scheme is very limited, and if we were to prescribe outside our license, it would not cover us. A lot of people are asking about referral systems on the Facebook group. So this is what we call the electronic referral system. It used to be called Choose and Book, but the new name for it is electronic referral system. The NHS loves rebranding. This is a rebranding. So I don't know if the slide's very clear, but in essence, when you go to a GP surgery, if you want a referral, the GP can click into this system. The system will then identify whether the referral is urgent or routine. It will then, so you get an option of urgent, 2-week wait, or routine. 2-week waits are for fast track for cancer patients where we're significant concern that there might be a cancer process going on. Following on from that, there's a section that says speciality, and that lists all the specialities. So we then pick what speciality we want to do the referral to. Next, so if we pick for TOFs, we pick GI and liver, which is upper GI medicine and surgery. We then get a breakdown. So when we pick that, we get a breakdown about what's in those specialities. So we would pick upper GI, including dyspepsia, quite commonly for patients with TOF. Yeah? At the bottom of the page, you can see that there's refine your search. So it tells you the postcode, and then it tells you distance within X miles and how you want to find the hospital of choice. That's what we get next. So once we go from that page, we've filled in all the details, we've written upper GI, we've written gastro specialist. We then click at the bottom corner to say search all, and it will give us a list of the range distance-wise, the appointment type, the service, and then an idea of where the hospital is. Yeah, so I work in Wolverhampton, so a lot of these are in the West Midlands. So there's nothing stopping you from going anywhere in the country. There is no increased charge for sending you to Great Ormond Street versus sending you to Wolverhampton Royal Hospital. There's a set charge for a first appointment. But in most GP surgeries, this process is done outside of the consultation. So if you want to go somewhere specific, either write down for the GP where you want to be referred, or ask the GP to let you do this part of the process yourself. And there is a way that you can actually just do this part of the process yourself. You go online, they give you a username and password, and then you can actually select the specific consultant yourself. The problem with that is that a lot of the specialties, when you click into them, will not list the consultant. You're just booking into the specialty. Yeah? Equally, a lot of the specialties will have exclusion criteria, and they might say, we don't see anybody outside a 30-mile radius. So that's the limitations that we have. But if you want to see a specialist, there's nothing stopping you from seeing a specialist. This is the system that we use. It is always quite helpful to ring the consultant secretary for whatever you want to be seen and asking them how they would expect a referral in. Is that my red card to say? Oh, sorry. The doctors don't do routine assessments. I'll be really quick, but the doctors don't do routine assessments. We don't because we are actually paid to do routine assessments on people with chronic diseases like heart, stroke, COPD, and these conditions. And we're inundated with those, so we don't have capacity to do routine assessments. If you want a routine assessment, put a note in your diary, go and get a routine assessment. So the really quick slide about what to do in a consultation. We often say to parents and patients, if you're expecting to be examined, don't come in 20 layers. Yeah? You've been sitting in the waiting room for half an hour, take your coat off, take your jacket off, take your jumper off. And if you're going in with a chesty cough, you're going to get your chest examined, be ready for that. If you've got a baby, I saw a mum the other day, the baby had 4 layers on. So you can imagine how long it took the 4 layers off, and then for the examination to take place in a 10-minute consultation. Work with your GP. We like to do shared decision making, so if you've read up about something and you want to share the decision, we like to support that. I did want to, this time around, because I missed it last time, just do a 1-minute quick whiz of benefit system. When we have, and this is quite common on the Facebook group, about whether children with TOF can get DLA or not. And when people are applying for DLA, actually for children, the system is very, very functional. It works. Whereas for adults, it doesn't. And there's been a massive change in the way the system has worked for adults with the introduction of universal credits. Generally speaking, the system is looking for functional problems, not medical problems. So if you've had 5 heart attacks and 10 strokes, it doesn't matter. They will still ask you whether you can walk 200 meters, whether you can pick something up, whether you can do X, Y, Z. Okay? Because we all know that there are the exceptional people who do have 10 heart attacks and then run a marathon. But we also know the people who have had 1 heart attack and can't walk from here to the chair. So the benefit system doesn't look at that. They look at the functional. So the TOF is important, but how does it impact on your life? The system often asks you to talk about your worst day. Sorry, your normal day. I would suggest that you talk about your worst day when you're filling in the application. The application is something like 40 pages long. So I would suggest you get it, you download it, you fill it in electronically, and you keep a copy of it, because after 6 months or a year, they'll ask you to fill it in again. And it's easier to go back and edit it than it is to refill a 40-page document. But concentrate on the functional. How does this affect my function? It's not important to get a report from a GP, because the list of illnesses is really not relevant when it comes to making the decision about what's happening. Unless you've got a known condition like Down syndrome, where we know there's learning disability associated with it. But actually, even then, the function is more important. That's my little one now. I just thought I'd share the slide. It says, doing well. Don't forget your flu jab. That's my other 2. All ready for winter. And questions, I think we'll take it at the end, aren't we? Thank you.